Welcome, everyone, to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Tracy, have you heard of a procedure called gamma knife radiation?
I have, yes.
Actually, gamma knife radiosurgery? Well, it's a type of radiation therapy, actually, that is used to treat lesions in the brain, including tumors. Now, it's not really surgery. There's no incision, and in fact, that's part of the appeal.
No incision, no hole in the skull, and you go home the very same day.
How can you beat that?
Here to tell us more about gamma knife radiosurgery is Mayo Clinic neurosurgeon Dr. Bruce Pollock. Welcome to the program. It's great to have you here again.
Great. Thank you for having me back.
Thanks, Dr. Pollock. So it's a funny term, radiosurgery. Explain to us what that means.
Okay. It was basically a marriage of two disciplines. So you were combining radiation oncology and neurosurgery. And so when they came up with this concept in the 1950s, they essentially labeled this radiosurgery.
And radiation oncology would mean radiation for cancers, or
yes.
Radiation for tumors.
Yes.
Where does the gamma come in?
The gamma comes specifically with this device in that the radiation sources which emit gamma rays, which are very, very similar physically to X-rays, but because they were using cobalt-60, it released gamma rays, and so that came up with the idea of the gamma knife.
So you've identified a lesion in the brain, and you've decided that a gamma knife is appropriate to treat it. How do you make that decision, and what's the planning like?
Essentially, there's a number of factors we think about. It comes down to the size of a lesion, its location, and other patient comorbidities as well as patient preference.
So if a patient is ill, you might do this as opposed to surgery.
Correct. And if the thing that radiation does not do that surgery, meaning resection, does, is it doesn't relieve mass effect or size. So if it's a large lesion where symptoms are being caused by pressure on an adjacent structure, then the next step would be surgical removal. But if it's basically symptomatic related to location, but it's not very large, then often radiosurgery is a good alternative to surgical removal.
How is this different from regular radiation?
Well, typically when we think of radiation therapy, we think of larger field radiation where the dose is broken up over time, whether it's days or weeks. The older definition of radiosurgery was that all the radiation was given in a single session. More recently, it's been broken up that it could be up to 5 sessions, but with the gamma knife, it's almost always given as a single session.
And how long does it take? How long?
The throughput from showing up at the hospital to leaving typically is on the order of 3 or 4 hours. The actual radiation delivery can be as short as 10 or 12 minutes or as long as 2.5 hours.
And what holds the head steady?
We use a frame. The head fixation is based on a frame that has pins that actually go through your scalp and capture the outer portion of the skull. And so it's a rigid fixation. Once that's in place, then we do imaging, and then we use that imaging to identify the target within this frame. It acts like a map.
So does the gamma knife, in essence, remove the tumor, or what does it do to the tumor?
Basically, it acts like any radiation, in that the energy of the radiation causes disruption of the DNA within the tumor with ideally very little damage to the adjacent tissue. And so as the tumor tries to divide and grow, there's enough double-strand DNA damage that the cells can't match up their DNA, and then subsequently your own body comes in and eats up the tumor. And so for tumors that are slow-growing, they're where only 1 or 2% of cells are ever dividing at a time, these things will shrink slowly over the course of many years, whereas more malignant tumors where 30-40% may be dividing at any time often will show shrinkage within weeks.
Are a fair number of these that you do related to metastasis, meaning patient has lung cancer, kidney cancer, and the cells have broken off, gotten into the bloodstream, and metastasized to the brain and grow there? Is that a fair?
It's the most common indication, certainly with across the U.S. and the world. We still continue to do a large number of benign lesions here at the Mayo Clinic, as well as vascular malformation and functional disorders. But the workload of almost every radiosurgical center is brain metastases.
Vascular malformation.
Basically, the one we treat primarily generally is an arteriovenous malformation. It's typically a congenital lesion of abnormal blood vessels within the head that can cause a stroke or a hemorrhage. And so the goal of the radiation is to block off the blood vessels over time, and then blood can't get through the AVM, and then your risk of a subsequent stroke pretty much becomes zero.
So you avoid a catastrophic event.
Yes.
And how do you find those AV malformations?
Historically, the majority of them showed up after a hemorrhage. But more recently, as people get imaged with headaches and dizziness, we find a lot of incidental AVMs. And so the decision of making, we're going to intervene for your unruptured AVM is different, and patients' mindsets are very different. So if you come in after a stroke, you're much more amenable to thinking, I would have my head opened up for that. However, if you go in and say, I have some dizziness, and we say you have this thing that may cause a stroke in the next 30 years, an outpatient-based procedure is often more tenable to the patient.
Yeah.
What are some of the side effects of gamma knife surgery?
The immediate side effects are almost zero. There can be some local tenderness at the pin sites. There can be localized swelling, but you don't get hair loss and nausea and vomiting like you do with radiation therapy. We think of our early effects, and early to us usually means over months, where there can be swelling of the adjacent tissue that could cause headaches or potentially a seizure if it's in the right location. And then there's long-term effects that are getting less and less as our treatments get better. We're able to deliver the radiation more accurately. And so the amount of radiation that's going to the adjacent tissues is less today than it was 30 years ago.
So patients have that gamma knife procedure, and then how long do they wait to see if it worked? I mean, it's not immediate, is it?
No. It depends on the reason of why we did it. So for benign tumors, we typically would image you at 6 or 12 months later. For a vascular malformation, a year or so later. For a malignancy, we typically do imaging roughly every 3 months for the first year. On that imaging, we look at the tumor itself to see if it's responded. We look for radiation injury, but our biggest thing we look for on the follow-up imaging is more tumors.
Sure.
If we do a gamma knife procedure for a brain metastases, the chance you'll make another tumor within the brain in a year is roughly 50 or 60%.
And then you zap that one.
We often will zap it again. We have people that are frequent flyers and will come back 6 or 7 or 8 times over.
So the most common indication is for a metastasis, meaning a cancer that's gotten into the bloodstream and spread to the brain.
Yes.
And how big of a lesion can you treat?
If it's surrounded by brain, usually a 3 centimeter rule, which is slightly more than an inch in diameter, is about as big as we can go. But if it's a lesion that's against the bones at the base of the skull, often we can go quite a bit larger than that.
And your success rate, I assume, with AV malformations is very good.
Yep.
Benign tumors, you can pretty much cure those most of the time?
Very much, almost always.
And the malignant lesion, do you ever do primary cancers of the brain, meaning a cancer that started in the brain, didn't spread there?
Yep, it's very infrequent. There's a few indications in which we do it, but cytoreductive therapy or surgery followed by radiation therapy and chemotherapy is certainly the mainstay of care for that indication.
You said you're getting better at reducing the side effects. What is new in gamma knife surgery?
Over time, several things. Our imaging has gotten better. Our platforms for dose planning have gotten better. The devices itself have gotten better. And at this point, we're actually entering our 31st year of clinical practice with the gamma knife in Rochester. So we're approaching 10,000 patients. Our understanding of doses that we need to use, predictable side effects, when to image people, all these things have been accumulated over the decades.
Have you been here that whole time?
I have not been here that long. I'm coming up on year 24.
So just the last 5,000 for you.
About the last 5,000.
Wow.
That's right.
Gamma knife radiosurgery. It's an alternative to traditional surgery to treat several different lesions of the brain, benign tumors, malignant tumors, AV malformations. You know, it's safe. It's a one-time treatment, and you go home the same day.
All right, thanks to Mayo Clinic neurosurgeon Dr. Bruce Pollock. Thanks for being here.
Thank you very much.
Thanks, Dr. Pollock.